Hypophosphatemic rickets. The calcium phosphate hydroxyapatite insufficiency is the key elements in the pathogenesis of rickets, irrespective of its types, which prevents this appetite, prevents the chondrocyte program death, thereby bone proliferates, and doesn't turn into mature bone. Now, thereby it is rickets in children. In adult, it is osteomalacia mostly. It in children maybe combination rickets and osteomalacia. So the phosphate loss in the urine, phosphaturia, is by far the commonest cause of the hypophosphatemic rickets, and of which the commonest one is the X-linked hypophosphatemic rickets, because it is FAX gene mutation. It is 80% of all hypophosphatemic rickets. And other ones is autosomal dominant hypophosphatemic rickets, FGF23 mutation, and third group is autosomal recessive hypophosphatemic rickets type 1, type 2, type 3, the DMP1, ENPP1, and the FAM20C respectively. So their phosphate, the FGF23 dependent hypophosphatemic rickets, these children they do have increased amount of FGF23 expression. We know that FGF23 helps in phosphaturia and phosphopenia, thereby phosphate deficiency rickets, quite severe. And other rare phosphopenic rickets are fibrous dysplasia due to GNAS deficiency mutation, cutaneous skeletal hypophosphatemia due to NRAS deficiency mutation, tumor-induced no definite gene, and osteoglophonic dysphasia. You have FGF receptor gene mutation, FGFR1, and clotho gene mutation gives rise to your hypophosphatemic rickets with hyperparathyroidism. So apart from that, the FGF independent, not by FGF23. Now phosphaturia by that means tubulopathy giving rise to phosphaturia. They are hereditary hypophosphatemic rickets with hypercalciuria, SLC34A3 mutation, and X-linked hypophosphatemic rickets, Den disease, CLC N5 mutation, and you have hypophosphatemic rickets with nephrocalcinosis, SLC34A mutations. Here, the sodium phosphate co-transporter in the proximal tubule and little bit in distal tubule are defective, so they are unable to carry the phosphate inside the tubule, so it is being eliminated. Fanconi syndrome, generalized tubular neuropathy with phosphaturia and others, aminoaciduria, glycosuria and others, it also causes phosphopenic rickets. Cystinosis, CTNS gene mutated, and then your isolated drug like anticonvulsants, your antibiotic, and few more drugs, they can cause drug-induced 24-hydroxylase induced disease can cause hypophosphatemic rickets. So hypophosphatemia have hyperphosphaturia. So this is being calculated by TRP, tubular reabsorption of phosphate formula, 1 minus urine phosphate clearance by creatinine clearance, and rarely the phosphopenic rickets is due to drug medications, the absence of the food phosphate in the food, and GI tract disease and low birth rate, prematurity, surgery, and others. So how the X-linked hypophosphatemic rickets they do present. Their manifestations comes basically at 3 to 6 months. But because of the higher amount of phosphate in the new infancy, presentations may take 2 years. Usually boys are affected because it is X-linked disease. Girls can have asymptomatic milder disease, but may not usually they are the carriers. So the rickets over here is quite severe. Anthosymmetry and arthropathy is distinctive. Deafness, sensorineural deafness is quite possible, common. They have poor pulp, status, root canal, they malposition, tooth abscess, decay, everything is possible. And more notorious one, grave one is the Chiari malformation or syringomyelia. So what sort of diverse sort of presentations they have? A short stature, disproportionate short stature, and severe hepatic deformity. This triad is diagnostic of the your X-linked hypophosphatemic rickets. Clinically, when you treat the Julie solution, phosphate solution, 4 to 6 times daily with oral phosphate 30 to 75 milligram per kg for until disease is quiescent, and with calcium calcitriol 125 dihydroxyvitamin D3 and Julie solution or neutral peptidase form, and then and this is the standard or a conventional treatment. When it fails to bring the response, is how do you understand response? Clinical resolution of the pain and everything by 2 weeks, and resolution of the calcium phosphate PTH level by 3 weeks, 1 to 3 weeks, and alpha alkaline phosphatase by 3 to 6 months, and bony corrections by 1 month, and your finally deformities in the limbs and chest they go by up to 2 years. So non-response in the time schedule of they are being supposed to be corrected is the non-response. In those cases, all patient who had complications with the calcium phosphate and the vitamin D3, there should be your given the Burusamab therapy, monoclonal antibody, or non-compliant cases. And but Burusamab should be weekly interval IV doses, and that should be given until the disease is quiescent or controlled. The but do not go for overzealous correction because too much phosphate will give rise to the raised PTH and thereby will cause for again phosphate loss. So thereby PTH should be kept to the upper side, lower little bit in the upper side, and phosphate in the lower normal side. These children may also need iron supplementations and other nutritional cares, and your corrective osteotomy, the deformity, when you will correct, wait for 2 years and make sure that disease is not coming back. Then you go for the corrective osteotomy. This is almost lifelong disease. And so other hospital indicates common to uncommon treatment of the underlying cause and lifelong treatment of most genetic disease. Prognosis a little bit guarded in some of the cases. Secretive progression is quite common.